Okay, Assalamualaikum. Very good morning, everyone. First of all, I would like to thank Prof. Tuan Kamarul uh, for the invitation for these MRP sessions. I believe Dr. Kamarul have given all of you the very good insights on the chronic pain research and management. And then I will share more on the acute pain management. Okay, and before I proceed with my presentation, I just want to share you the video that I have here. Okay, dah share ke ni? Okay, okay. Slideshow. Okay. And you can dia ada video ni. Sama. Lama. Invalkan sila input sepeda. Itu kan tulis. Guys, bawa ni. Sorry, we have to stop for a while for the technical glitch here.
Yes, yung ito. Nako dong.
Okay, we'll continue again. Sorry for the technical glitch. I don't know what happened just now. Okay, from the video we saw just now, it is actually the awake craniotomy being done, where we actually did the intraoperative neurological assessment in terms of the assessing the language of the patients, you know, and also we also assess the motor function of the patient as well during the surgery at the eloquent area. So, during this awake anatomy, which I think now become a necessity, it's not only a choice, our main principle of management as anesthetists will be optimizing the monitored anesthesia care, you know, by means of tailoring the needs and the depth of anesthesia according to the stage of the surgery. And also the other thing is to provide analgesia with a scalp lock. Okay, whenever we look at this, scalp block has been one of the mainstay of therapy or management in awake craniotomy. And from this, I would like to explore a little bit more on the a role of scalp block in terms of providing the post-operative pain management for the patient. That's why we have come out with this study, the scalp block versus intraoperative Parecoxib. You know, we usually use Parecoxib as a post-operative pain management. We want to compare between the scalp block versus intravenous Parecoxib for the patient who actually undergo cranioplasty, and we want to compare the pain score and the morphine requirements of the patients. Okay, this research actually involved master student Dr. Nur Shahirul, the neuroanesthetist Dr. Laila, Prof. Naza, and me as well, and also the neurosurgeons Prof. Zamzuri Idris. And it is done here in Hospital University Science Malaysia under the Department of the Anesthesiology and Intensive Care and also Department of Neuroscience. And it is actually get the ethical approval from the local JPAM institutional review human ethics boards, and we also registered the study under clinical trial registrations. And there is no declaration in terms of funding. We do not have actually funding for this study. and there is no AI used for the preparation of the manuscript. But however, I have to declare that in terms of providing you with the PowerPoint presentation today, I actually use Notebook LM. Okay, as introductions, cranioplasty is always neglected in terms of the intensity of the pain. We usually think that cranioplasty pain is, a light pain. But in fact, based on most of the study, the cranioplasty pain is actually moderate and can also be severe as well, especially in the first 48 hours of surgery. Okay, and then the pain actually coming from not because of the dura is actually open, because in the cranioplasty we do not open the dura, but the pain actually coming from the skin and the precranial muscles that actually cause the significant inflammations. And whenever we're dealing with a neuro patient, we try our best not to use, a long-acting opioid. And in fact, if you can avoid the use of opioid, that's even better. Okay, because opioid can actually cause nausea and sedations and mask the neurological assessment. And as time goes by, we are now going towards eras, enhanced recovery after surgery, where the role of multimodal analgesia comes into place, where we actually use local anesthesia and NSAIDs a lot more in order to provide analgesia for the patients. And in order to address the research gap, you want to see whether is there any role of the scalp block in terms of providing effective analgesia for the patient for a better pain relief for the patient post cranioplasty surgery. Okay, this is just a illustration of the scalp block. We usually use 6-point scalp block location based on the anatomy of the scalp. First of all, supraorbital and supraorbital, we have to see the landmark, which is our supraorbital groove. And then zygomatical temporal, we actually see the lateral canters of the eye. And our auricular temporal, actually, we have to palpate for the superficial temporal artery for us to give the scalp block. Okay, and greater and lesser occipital is determined by palpating the occipital nerve. And from there, we have to inject the local anesthetics. Of course, we have to use the smallest needle because this is a quite painful procedure. And then for the analgesia per se, we usually use the concentration of bupivacaine of 0.375 with 1% of ipnocaine, and by giving 1.5 to 2 cc's solution at each location of the scalp block. And of course, we have to know where is the distributions of the nerve for us to actually target where is the exact location that we want to provide analgesia with. Okay, this is just I actually yeah. This is just for me to illustrate the published to see where is the lesson. Okay, this case was done in hospital called Cry, where they actually invited me for awake craniotomy for the laminectomy. So we did the scalp block there and teach the anesthetists at hospital called Cry on how to actually give scalp block in these patients. So basically, this is the gist of the study, the scalp block, yeah, that we are using for the postoperative pain this time around. Okay, so what are the objectives of this study? For the general objective, we want to compare between the scalp block versus conventional intravenous Parecoxibs in terms of the effectiveness towards the postoperative cranioplasty pain management. The specific objective number one, of course, you want to compare the post-operative pain score, where we actually measures the visual analog score during the first 12 hours. It is measured at 1, 2, 4, and 6 and 12 hours post-operatively, to see the pain score of the patients. we also want to see the total morphine doses that the patient needs and the time to the first rescue analgesia, which is the PCA morphine. And we also want to see whether is there any difference in terms of the side effects of the the comparison between the scalp block versus the conventional IV Parecoxib. Usually it is related to extensive or excessive use of the morphine. Tak kena gerak. Okay. For the baseline characteristic of the patient, we included patient with the age of 18 to 60 years old, those who ASA 1 or 2. We include those patients who only have full GCS, meaning that this patient are able to actually perform the visual analog score postoperatively. And we also include those patients who undergo elective cranioplasty surgery under general anesthesia. And what are the exclusion criteria for this study? First of all, if the patient has an history of allergics towards the study medication, particularly if the patient has allergic to local anesthesia, NSAIDs, or if the patient's being pregnant, we have to exclude them as well. And if the patient has underlying bronchial asthma, since sometimes for those patients who has bronchial asthma, they might actually have attacks upon instruction of Parecoxib. And we also exclude those patients who has the platelets count of less than hundreds. And also there's also the withdrawal criteria, meaning that if we have this kind of patient, we have to withdraw them after randomization. And those patients as particularly is those patients with reduced surgery, or those patients who has massive bleeding after surgery, or require intensive care post operations, meaning that the patient is not being able to actually perform the visual analog score post operatively, or if the patient actually have problem with hemodynamic instability or need for ventilator support post post surgery, then we have to remove them from the study. So we have a total of 42 patient randomized to two different groups, meaning that 21 of them received the scalp block and another 21 of them actually received IV Parecoxib. Okay, we blinded the patients, and also we blinded the assessors for the study. Okay, and also for the scalp block, we actually specifically use 0.375% of ropivacaine plus 1% of lidocaine, and we administer at least 6 point regional subcutaneous block or scalp block. And then this scalp block is actually performed after the skin suturing completed. Why we did that? First of all, because we want to make sure that the bone is there to increase the safety of scalp block. That's the first thing. And then we want to actually achieve a longer duration of the analgesia post-operatively. Okay, and of course, conventionally, most of the patient, traditionally they will be given IV Parecoxibs, 40 milligram at the skin closure. Okay, so we compare between these two groups. Okay, and we use visual analog score to assess the pain score at 1, 2, 4, 6, and 12 hours post operations. And then in terms of the rescue protocol or rescue analgesia, we put all the patients on the PCA morphines, meaning that if they have a pain score of 4 or more than 4, they are able to actually press the PCA morphine and get the analgesia from there. And we also assess the usage of PCA morphine of each patient. Okay, what do we found as a result of the study? First of all, when comparing about between the scalp block and Parecoxib, we actually found that 65 at 1 hour post surgery, they has actually 65% lower initial pain score in the scalp block group, as compared to those who are actually given Parecoxib. So meaning that those who are given IV Parecoxib, they have a higher pain score. Okay, and if you're looking at the pain score at 1, 2, 4, 6 hours, they are statistically significant based on the repeated measure ANOVA between comparison of two groups, okay, at different time. And however, at 12 hours, there is no significant difference in terms of the pain score at 12 hours post-operatively. The second thing, we're looking at the dose of morphine. Okay, in terms of total patients who actually requires PCA, you know, it's only one patient actually requires PCA for the scalp block, and 8 of them actually requires PCA morphine in those actually given Parecoxib. And this actually shows drastic reductions of in terms of morphine requirement in those actually given a scalp block. And however, the total morphine dose in each patient who actually press their PCA, there is no significant difference. And in terms of the time towards the first PCA press, you know, mean time towards the first PCA was actually not significant as well. The significant thing is only for the percentage of the patient who actually requires usage of the PCA morphine. And the third thing, of course, we are measuring the side effects. In terms of the side effect of morphine, of course, nausea and vomiting. Okay, and related to the results just now, result 2 just now, we can actually expect that those who are given Parecoxib, they actually has a high incidence of the post-operative nausea and vomiting versus those are given the scalp block. They actually, none of the patient actually complain of the post-operative nausea and vomiting. So, in terms of the scalp block, you know, scalp block actually provide targeted multimodal analgesia by giving specific regional anesthesia to the areas. So it is first actually being introduced in 1996, and since then there were extensive usage of the scalp block for intraoperative awake craniotomy management and also post-operative craniectomy or neurosurgery management as well. Okay, and the scalp blocks in the meta-analysis shows that for those who are actually given scalp block post-craniotomy, they actually have a better pain score, in terms of the after the meta-analysis. And then in terms of the preemptive analgesia effects, by using ropivacaine, we actually found that those actually given ropivacaine has the effect lasting up to 12 hours durations. And studies actually has found that for those who are actually given a scalp block with the assistance of the what we call this ultrasound guided scalp block incisions, those patients has a longer durations of analgesia profile. Okay, and in terms of the morphine requirement, there is one study actually in the post craniotomy patients, because there is also extensive damage or inflammation and including the dura opening. One study actually shows there is no significant difference in terms of morphine requirement. However, we actually found that the morphine requirement in cranioplasty is much lesser than actually added the benefits of using the scalp block for those patients undergo cranioplasty surgery. So in conclusion, for our clinical practice, of course, scalp block reduces post cranioplasty pain significantly as compared to IV Parecoxib. And I think this is the way to go in terms of using scalp block as the adjuncts and mainstay of therapy for post-operative pain management in the patient who actually had post-cranioplasty. And study limitation, of course, the patients, adult patients, and then non-standardized surgical variable. Sometimes the patient has bitemporal canoplasty being done. So this kind of patient might actually elicit more pain. And we actually have short observation window until 12 hours only. maybe we need to continue a little bit more up to 48 hours for us to see how does actually the scalp block performs in the first 48 hours after surgery. And of course, we have to design the multi-center trial in terms of trying to, to expand the usage of scalp block in the general populations. Okay, the study is actually published last year. Okay, after 3 to 4 years it's being completed. And with that, I thank you.